Um, where are we today in 2023? I mean, are you serious that we really can pick up cardiac abnormalities in the first trimester? And I would say, yes, it is possible. And I think one of the first questions somebody always asks me is, well, show me how. I mean, how do I actually make the diet? What are the machine settings? What probe do I use? Do I do a transabdominal? How long do I allocate? What do I set my PRF? What's my power? What's my gain? What's my sector width? And all these sort of practical questions. So I just want to give a very quick introduction on firstly where we are today and then the practical settings of a machine. And I hope that you can take these practical tips and put them into play when you go to work on Monday morning. And you don't have to be in a position necessarily where you identify every anomaly sequence because there's about 50 different anatomical abnormalities or cardiac abnormalities. But you do need to know in recognizing a normal heart. So for many of you, your role is to distinguish between normal and not normal. And then when it's not normal, then refer it on to somebody who will actually work out which of these 50 different sentinel abnormalities you're looking at and cancel the patients. And I know that there's varied levels of expertise of people who have joined us this evening, and I'm cognizant of that. So I will touch on some very basic stuff, but there'll also be some very advanced practical clues I will give with regard to 4D evaluation, because I find that a very valuable tool and certainly a teaching tool in the first semester of pregnancy. So you say to me, okay, Simon, look, really, should I be looking in 2023? And the answer is absolutely yes. And if you, in fact, look at it over the last 10 years, you see back from 2011, where detection rate was about a third. We're now moving into the arena where detection rate in 2021 is about two-thirds. And these are three huge population studies. And you can see progressively over the years, the last 10 years, that the detection rate of cardiac malformation is improving. Now, if you ask me how and why that's happened, I would say to you that technology plays a role, but probably the greatest role of all is a systematic approach to examining the heart and the belief that you can achieve it. Because in many instances, when you're examining the heart the first semester, it doesn't pop up to you in a beautiful four chamber and an outflow tract. You really have to work very hard at it, and you have to be patient because the fetus is quite active and moves in and out of view. But as a general rule, that plays to your advantage if the baby moves a lot in the first semester of pregnancy, because you'll ultimately get to the point where you freeze a short segment, and with the use of Cineloop, you can rewind and identify that it is normal or abnormal. So I think pushing the machine, being patient, and allocating time, absolutely, you can reach where we are in 2021, where two-thirds of abnormality can be identified. And this is an article which you heard, for those of you who are at ISUOG in Korea recently, you will have heard of on many occasions this article being referenced, which is Jehan Karim's work from Iris Papageorgiou's unit on first trimester ultrasound detection of cardiac abnormalities. And this is a review of all the published data. It's 63 studies, 328,000 fetuses that were examined, where there was a reference standard of outcome, either a postnatal diagnosis or a postmortem evaluation. And I know it does expand over a very significant period of time. I've just mentioned that this expands over a 22-year period. Of course, the detection rate has improved as the years advance. And when you look at this, it's divided the outcomes into two groups: those who are low risk, where the detection rate was about half of these, and those patients who are high risk, say a previous baby with a cardiac abnormality, or a mother exposed to tetragens or an increased nuclear translucency, then the detection rate was 68%. Now, you may turn around and say, why would the detection rate be any different in a high risk group to a low risk group? Is it that you're simply looking a little bit more closely at a high risk group? And that's exactly it. And that's why it is better in that group, because you're looking more closely. Well, that sort of doesn't make sense. I think every patient should be treated equally, and you should look more closely with every patient. You should have a systematic approach. In fact, this came out very nicely in this paper and was sort of tucked out of view. But I think I would like to bring it to the forefront and put it on this slide, because at the very bottom, it says in this slide that the detection rate in the low risk was the same as detection in the high risk if you did a four chamber view of heart and the outflow tracts in 2D and color. And that's absolutely for me, the most important take-home message in that paper. So if you look at it at that analysis of huge studies and wide population studies in different countries, is that 2/3 of cardiac abnormalities can be identified. In fact, this represents 80% of all cardiac abnormalities detected prenatally can be detected in the first trimester. A very important take-home message. Now, you say, why is it so important? And I'll tell you why it's so important. Because we are entering a new arena in genetic diagnosis. We've spent the last 25 years screening and detecting cardiac malformation, not just in the first, but in the second trimester. And we then offer patients an invasive genetic testing because we know there's an association with a genetic background. And if you look at it for chromosomal, it's about 14 to 15% will have an aneuploidy. And then more recently, with chromosomal microarray, we've recognized there's an additional yield of about 5 to 6%. So we know that about 20% of all prenatally detected cardiac abnormalities, 1 in 5, will have a genetic basis to the abnormality. But what's more relevant is for 2023 going forward, is that more recently that data has shown that there is an additional yield of 10%. That's very important, of 10% of monogenic disorders. So having excluded chromosomal, aneuploidy, and copy number variants, that an additional 10% will have a monogenic basis to the structural cardiac malformation. And if you find on top of a cardiac abnormality that there is an additional finding, whether it be a talipase or a polydactyly, that there is an additional yield in the order of 15 to 35%. So up to 1/3 of these babies who have an extra cardiac malformation with a normal chromosomal microarray will have a monogenic disorder. Now, why is that so important? Because if you look at the time it takes to do an invasive genetic test, get the results back from your banded karyotype or your chromosomal microarray, then bring back the patient and cancel them regarding exome studies, go through a multidisciplinary team before it's approved, then initiate bloods from both parents to run a trio, then wait for the results to come back, and then to sit down with them and tell them what the result of the exome sequencing is, you're well into 26, 27 weeks of gestation on current modalities of identifying the abnormality mid-trimester. It becomes so important to bring back and make the cardiac diagnosis in the first trimester, because if you do that and make the call in terms of the timing of genetic testing, you will have your answer by 17 to 18 weeks of gestation. There is a huge difference between making a diagnosis of a monogenic disorder at 17 weeks when compared to 27 weeks of gestation. And that, for us, brings probably the greatest importance why we need to push for making cardiac diagnosis in the first trimester of pregnancy. The other added advantage is, of course, when you make a diagnosis in the first trimester of pregnancy, is that you can counsel a patient very early in the pregnancy so they are prepared for what lies ahead, that you bring in a pediatric cardiologist, and that you set up a whole multidisciplinary team to align where and when and how she is going to be delivered and how the family are counseled and brought up to speed. And the luxury of time that this brings with first trimester diagnosis is so crucial. And then there's the third group who are associated with multiple abnormalities or incompatible with survival or lethal cardiac malformation, where you make the diagnosis of pregnancy early in gestation. There are many practical and psychological benefits to those patients who do not want to continue with the pregnancy. So the push is there and the evidence is there that we should detect 2/3 of major abnormalities in the first trimester. And in a sense, this is why ISUOG has come on board with looking and agreeing that the way forward is to routinely use color Doppler. Now, that has only been adopted in 2023. I'll share with you that for the last 25 years in our unit, we've been using color Doppler to evaluate and detect cardiac malformations, but that's in the setting of a high-risk unit that's dedicated to fetal cardiac imaging. And I sense there was always that concern, and rightly so, about the indiscriminate use of color Doppler and exposure to the fetus. But the realization of the power in the screening context of power Doppler in the first trimester is real and is with us. There are two guidelines, and you need to know about them. The first one is the general cardiac guideline on the left, and the second is the cardiac guideline related to the first trimester. And if you look at, I plucked out from the first, on the left-hand side, the issue practice guidelines for fetal cardiac screening. And if you read here at the bottom, cardiac screening should be based on determining the situs and obtaining the 4-chamber view and 3-vessel tracheal view. So that is from the general paper, but from the first trimester and doing a dedicated first trimester anatomical assessment, you can see there's far more information here, which we need to look at. And not just the 4-chamber, but looking with 2D and color, but also looking at the left ventricular outflow tract and 2D and color and the 3-vessel tracheal view and so on. Let me put that to you in a pictorial form because it's always much easier. If you are out there practicing, you're saying, I'm not a high risk fetal echocardiogram assessment person. I'm somebody out there who just wants to make sure that the baby I'm scanning is normal. Well, if you are, this is what you need to do. You need to provide a split image showing or a cine loop image showing a 4-chamber view of heart and a 3-vessel tracheal view. Because if you show that image, you have excluded the vast majority of major structural cardiac malformation. It's such an important image. And in my unit, the staff, when they arrive, new members of staff, they have to provide 100 images of exactly this split image showing a 4-chamber, because once you're able to sweep from one to the other, back and forth with the correct settings, you will have mastered after 100 images. I'm comfortable that then this person knows how to examine a normal heart in the first trimester. If you want to go a little bit further in terms of doing a detailed cardiac assessment, as is part of the first trimester guideline 2023, well, then you extend it to including the left ventricular outflow tract after the 4-chamber, sweeping up to the 3-vessel and the 3-vessel tracheal view. So you will see there is additional information that is provided in these additional section images, which in a sense, if you look at it, look no different to what you're looking at the heart at the mid-trimester examination. That's where we are in 2023. Now, I'm going to walk you through a case which we saw very recently, and I'm going to show you by way of example of stepping into a room with me tomorrow morning. If you were in the room with me tomorrow morning and I showed you this image at 10 to 5 as we were just about to leave the practice, you would say to me, Simon, that's a shocking image you're showing me. I would absolutely agree with you. I would turn around and say to you, I agree it's a shocking image. I can barely see the heart present, but I can see there's a pulsation. I can see it's alive. But if you look at that heart, it represents maybe less than 1% of the entire canvas of imaging I have available. And it's a shocking image because the baby's in a terrible position and there's no magnification, there's no optimization. So what do? Do I give up and say, oh, look, I'm not going to be able to see the heart and go home? I say no. The first thing is I select my transducer, and I select my transducer as a 2 to 9 megahertz transducer. I will reduce my sector width. I'm going to go to the next page. I will magnify the image until I have a decent size image showing for me a 4-chamber view of heart, but also I want to check that the heart is on the same side as the stomach, because I've established by looking at the spine and the head that the stomach is on the left-hand side. And I can see as I draw a line up through the vertebral body here that 2/3 of the heart is in the left chest and 1/3 of the heart is in the right chest. And the axis of the heart, which I don't actually measure, but if I simply visualize that as about 45 degrees plus or minus 20 degrees, is normal. But that's a lot better than what I started with. I'm getting a little bit closer. The next step is to put on color Doppler. And all of these segments of imaging was taken from my sonographer who did this examination. I went back and selected the images from her exam. And when she looked at color, she set the PRF at 23 centimeters a second. That's perfect, because the PRF should be between 20 to 30 centimeters a second for first trimester cardiac examination. She chose color to start with. I'm absolutely fine with that in the first instance, but I'm going to talk to you about progressing from color to power to slow flow. And you will also notice that she has inverted the image. Now, remember, in the first trimester of pregnancy, the spine is not completely ossified, and you can absolutely image through the spine. And if you image through the spine, you will find it's much easier to understand or interpret your 4-chamber or section out of the heart if it's inverted, so you have the apex of the heart up. And you can do that in the first trimester. And in fact, if I can just interject a sentence, you can do it at 10 weeks. It's a beautiful time because there's no spinal ossification. So for me, looking at the heart at 10 weeks, whether it's up or down, just makes no difference whatsoever. I'll get the same quality of imaging. So the sonographer's inverted the image, she selected color, and she selected a PRF 23. I'm absolutely fine with all of that. She's then frozen the image and she split an image and then sweeps to a 3-vessel tracheal view. And then when she sees there's only one vessel on the 3-vessel tracheal view, she then raises the alarm bell and she calls on me. I'm in scanning in the room next door. It's taken from 53 minutes to 55. In a period of 2 minutes, she's gone from a shocking image of a tiny heart in the middle of a big canvas to a blown up image with the correct PRF and magnification, showing a 4-chamber and 3-vessel tracheal view that does not fit with a normal ISUA guidelines, certainly in the 3-vessel tracheal view. I take a couple of minutes to get into the room. If you're looking at the timing here, the top right hand corner, because it takes me 5 minutes to get in there. And at 7 minutes past 5, I come into the room, and the first thing I do is I slightly increase my PRF. It's up to 31 centimeters. This patient is 31 weeks and 3 days. I then move from color Doppler. I then chose to power Doppler, and I sweep from a 4-chamber to a 3-vessel tracheal. I then do split imaging. The baby is turned around. I don't need to invert the image, and I make that point that if you wait, the baby will move in the first trimester. So it's actually something not as a disadvantage, but as an advantage. And you see here that I used CineLoop to capture it. So I know it was only a short period of time, but I caught it and I used CineLoop. So now I've changed the power, I've increased my PRF, and I've used a CineLoop. And now I've demonstrated that I have reversed curvature of the vessel coming out of the right ventricle. So the vessel is coming out of this right anterior ventricle, which should go in this direction, but is going in a reverse direction. So now I've recognized that there are 2 vessels with reverse curvature of the vessel coming out of the right ventricle, a finding typical of transposition of the great arteries. I then move from 1708 to 17, 2 minutes later, I then rotate from a 4-chamber to a 5-chamber and then heading towards the arches. And you'll see that the image is inverted. You will note with the image that's inverted using color that I have also inverted the color scale. And that's a very important thing to do, because if you're examining the baby upside down, and you always have to have it that inflow into the ventricles is red and outflow on the 3-vessel tracheal view is blue. That has to be a systematic thing you do in every single examination, because it then becomes absolutely ingrained in your brain that you know what tricuspid valve regurgitation is. It's always blue. It becomes ingrained in you, when you've got turbulent flow across the pulmonary or aortic valve, because it'll be red. So you have to do exactly the same thing. So if you're scanning the baby in an inverted position, you need to invert your color. And that's exactly what I've done. I've changed my PRF down to 23 centimeters a second. So I haven't kept my PRF up at 33. I'm manipulating my PRF constantly. And let me stop at that point and say there are 3 key controls that you control. The first is the PRF. You set the PRF as number 1 as the priority. And after you've set the PRF, then you go to your power. Once you've gone to your power you will set with these newer transducers around about 95%. And you do not go to 100% of the first trimester with these newer machines. You don't need 100% power. And the third thing you change is the gain. PRF, power, gain, always in that order in imaging the first trimester. So I won't explain to you why, if you did it any differently, it's a mess. It won't work for you. You will get the wrong answer. That's probably the single most important take-home message in this talk. So this is where we started. We started with an absolutely lousy image in a baby in a terrible position, and we ended up with an image, split image, showing a 4-chamber view of heart and a 3-vessel tracheal view, and then we went to a 5-chamber view onto the just slightly oblique on the arches, and we have findings typical of TGA. And that was in a period of time that was over 5 minutes of scan time in making that diagnosis of simple transposition of the great arteries in the patient who was 13 weeks and 5 days. But it walks you through the technique of reducing your sector width, magnifying, selecting your PRF, using color Doppler, moving to power, inverting your image, going through the section analysis of the heart, using CineLoop. All of these techniques are absolutely critical. And most of all, above all of this, is the belief that you can get a 4-chamber view and you can get a 3-vessel tracheal view. And every sonographer in my unit can get a 4-chamber and a 3-vessel tracheal view in fetuses 11 to 14 week scan. Ideally, we book it at 13 weeks of gestation because they have had prior cell-free DNA. So then the other thing I'd like to mention to you is that with regard to the first trimester, it's a unique time and very different to the second trimester because quite frequently we'll have associated structural abnormalities. So when you've detected a cardiac abnormality, let's say this baby at 11 weeks, if you look at this image, you can see at the very beginning that you have a heart where the right cardiac ventricle is underformed. So this is the descending aorta defining the left atrium, the left ventricle, and there's no right ventricular cavity. So this is a baby with a hypoplastic right heart. Pulmonary atresia with intact ventricular septum. But for me, when I see something like that, I go through examining the heart in detail. But the next thing I want to know, is there anything else? Because if we look here, this is the liver, which is herniated into the base of the cord. It's the same texture as the liver. It's not a bowel omphalocele minor, it's a liver. Now, if I get a chromosomal microarray that comes back telling me that's normal, I am moving to an exome sequencing because there's up to a 30% chance that this baby is going to have a monogenic disorder. And I'm 11 weeks of gestation when I'm making the call of doing the CMA. So I'll get it by 13 and I'll have the exomes by 15 to 16 weeks, 2 to 3 weeks. See the importance of that? And another example to make mention to is not just associated with structural abnormalities, but for aneuploidy, there's a higher incidence of aneuploidy with cardiac abnormality in the first trimester when compared to the second trimester. This becomes particularly relevant in this baby because the cell-free DNA in this baby was low risk on screening, and it had a dilated fourth ventricle and an abdominal circumference that was well below the first centile. And you can see in a split image the difference between the AC and the HC. The AC is well below the first centile, a tiny abdominal circumference and a thin placenta. All of these findings typical of digonic triploidy, which presents with a negative NIPT. So in the platform that we're using with a Illumina, if you use a SNP-based NIPT, you will pick up digonic triploidy. We are not using SNP-based. And then you move on to a color Doppler examination. You see a single large vessel here, your pulmonary artery, with your aorta, with no vessel coming out of your right ventricle. So tetralogy of Fallot with pulmonary atresia, with the aorta sitting astride the ventricular septum. So the importance there is of understanding a higher association with aneuploidy. So I'll finish up by saying you can read our review by Vavchi Ryder, who's published in our screening for congenital heart defects in the first trimester of pregnancy. And I think probably the most important table from this paper is the settings for both grayscale and color Doppler, many of which I've addressed in this brief introduction today. But remember, you have to drive your ultrasound system in order to get them maximize the benefits out of color Doppler. And for most diagnoses that we make for major tract abnormality, we are absolutely dependent on color. Remember, for frequency, always try and use the highest frequency, understanding that you lose out in penetration. But these are two patients, the same patient showing two images. This looks like a mid-trimester heart, but it's actually a 13-week heart. And this is the same patient with a 2 to 9. And you see, you can barely make out there's a hypoplastic left heart. But if you use a higher frequency probe, you can see how much easier it is to see. And again, don't forget to split your image. And just such a useful thing to do. So if you look in this image here, if you look here, you split it, you now demonstrate that the configuration of where the duct enters the aorta is abnormal. And again, you will begin to recognize that as you routinely image. This is the pulmonary artery, which is much smaller, and it should actually be inserting here. That's abnormal. You may not know what it is, but it's abnormal. In this case here, it shows with color Doppler, you will see a 4-chamber view of heart and a 3-vessel tracheal view, which looks fine. But then you move to power Doppler and you get better definition of the ventricular fill, and you get better definition of the 3-vessel tracheal view. But then you move to slow flow, because both power and color looks normal in this baby. But when you move to slow flow, you see you get better ventricular fill. You can see all the great arteries, but now you see there's an aberrant subclavian artery. So in terms of slow flow, I haven't mentioned an awful lot about it, but when you're looking at tiny vessels, the internal thoracics, the right aortic arches, double aortic arches, the absent ductus venosus, the aberrant subclavian arteries, the persistent left superior vena cava, for the subtle cardiac abnormalities in the first trimester, I'm absolutely dependent on this technology. And it is hugely powerful and valuable. I will mention about, I've spoken all along about split imaging, But there's also another type of split imaging where you're real time looking on 2D and at the same time in color. And I use this in the second trimester as well, because it allows me to look at flow across the AV valves at the same time as looking at the AV valves in 2D. The machines nowadays can cope with the frame rate of doing that. And that becomes very valuable in working out subtleties like pulmonary valve regurgitation. If there's not only turbulence after the valve, but there's also flow back towards the heart. If you've got a split image, you can help you appreciate exactly where on the left side to get to the pulmonary valve in 2D, and the right side, you've got it in color. It's a super valuable tool in cardiac imaging, is to split real-time imaging rather than in a freeze frame showing 4-chamber, 3-vessel. And the other thing is really for high-end imaging, which I like to do, is to look at the stick imaging on the A plane along with the rendered plane. Using stick with the A plane, I like wide size VCI because it gives me a very quick 3-dimensional perspective of any cardiac abnormality I'm looking at. But that's a little bit beyond where we want to be today. So I might just stop there because I think we've gone a little bit over time. And I might move now on to the 6 clinical cases, which I'm going to show you, which have come through our unit. For each of these cases, I've selected out the poignant clips that show the abnormality, and I will walk you through these cases one by one, and then I'll go quiet as you have time to look at the clips in your own time and select the differential diagnosis. So we might start with the cases. And then once I've finished the 6 cases, I will then walk you through what the final diagnosis is, and you can understand why you got it right or why you didn't.